Hi, my name is Nick Kuntz. I'm a neuroradiologist at Mayo Clinic, Arizona. And so, I think everybody that's a neuroradiologist that's in academic medicine tends to have a talk on stroke imaging. And, for some reason, I've never actually recorded mine. So I thought I'd go ahead and put this together and get it out there. And really, this is an overview that's geared toward radiology residents, early neuroradiology fellows. But if you're a neurology resident, medical student, emergency medicine resident or trainee, I think this applies to a lot of people just because stroke imaging is so encompassing of what we do in terms of emergent medical imaging through the ERs. And, on top of that, it really is a team-based approach. So I think there's a lot of folks that can benefit from this sort of topic. Okay, so enough of that. I have no disclosures to make. I would like to thank a couple of people right out of the gates. First of all, Scott McNally, who's an amazing neuroradiologist at the University of Utah. He was one of my faculty and mentors when I was a fellow there several years ago, and he's really kind of one of the premier neurovascular imagers. And so some of the content provided here was from cases that he shared with me over the years. And I'd also like to thank my good friend and former colleague at Indiana University, Aaron Kammer, who also lent me a case for this talk. So thanks to both of you guys. Okay, so let's get started. Why are we talking about stroke? Well, stroke is incredibly common. It's the number 3 cause of death in the United States, and it's really the number 1 cause of lifetime disability. Now, if you survive your stroke, you may have long-term deficits from it, but there are many patients who don't do well up front out of the gate, and that's because they end up having massive swelling, what we sometimes refer to as malignant ischemic stroke. So all of that vasogenic edema causes really rapid and massive swelling, and that leads to brain herniation syndromes and potentially death. As we look at the types of stroke, you can really kind of break it up into 2 basic flavors. The majority, about 85%, don't quote the numbers exactly, but about 85% ends up being ischemic stroke. And that means that a sizable minority, about 15%, ends up being hemorrhagic stroke. And these are strokes that bleed up front. So at time of presentation, there's brain hemorrhage. And it's really critically important for you as a radiologist or you as a treating physician to recognize that, because that will change your treatment pathway immediately. Now, about 2/3 of the time, strokes will end up being of a thrombotic etiology, so some sort of in situ thrombus that forms and occludes the vessel. But about 1/3 of the time, it's from an embolic source. So you have to go looking for the source, whether that's from plaque in the carotid artery or something more central, within the heart. You do need to keep in mind that a big chunk of these strokes are the result of emboli that get flicked off and go traveling downstream and cause occlusion. As I hinted at before, it's not just a radiology issue, and you don't need me to tell you that. There's a lot of moving parts whenever it comes to acute stroke care. And radiology is obviously a very important member of the team, but it really starts even before the patient gets to the hospital with the pre-hospital and emergency medical services that are sort of the first-line responders and getting these patients triaged appropriately. Once they hit the hospital, there are defined stroke teams, usually consisting of neurology, emergency medicine, radiology, and neurosurgery. There's obviously a big nursing staff that's involved, technologists from both the lab and the radiology side of things. Pharmacy is an important part of this team because they're the ones that get the drugs together as far as treating patients if they're within the appropriate stroke window. And then once they've been treated, or if they're not treatment candidates, and they go to just sort of more of a standard type of treatment rather than endovascular management, these patients get admitted to the hospital, and obviously there are lots of team members that are taking care of these patients as well. So the bottom line is, if you're watching this lecture, you're probably someone that has an interest in this, and you're one of the many people that are involved in making sure that the highest level care is provided to these patients and that it gets provided in a timely manner. So from a radiology standpoint, as a diagnostic radiologist, what are your goals as a stroke imager? Well, the way I see it, you've got 3 main goals. First of all, when you look at that non-contrast head CT, the first thing I'm always looking for is blood. You want to identify hemorrhage because immediately that's the decision point in terms of patient management. Once you've assessed for hemorrhage, then you're looking to see, does it look as though the patient has core infarction, otherwise dead brain, or is there potentially ischemic penumbra? And we'll talk more in this lecture about how we tease that out. And then the third thing is to look for a large vessel occlusion, something that may potentially be intervened upon in an endovascular manner. So it's really important, if you're the radiologist looking at these images, you're the one that sort of directs or helps to direct the way that the patient gets treated. So treatment strategies really depend on you making these decisions and making these findings quickly and accurately, and importantly, closing the loop with communication in an expeditious manner. Okay, so let's talk a little bit, ever so briefly, about the pathophysiology of stroke. So you can kind of break the causes of stroke up into three main camps here. So first, we'll talk about arterial causes, things like thrombus and embolism that we mentioned before. Those are the most common things, but keep in mind there are other things that can occur and cause stroke, such as carotid dissection or a vasospasm in a patient that's had an aneurysmal bleed and their intracranial arteries start to clamp down and cause ischemia. Or some patients present with vasculitis, whether that's of a rheumatologic etiology, whether that's drug-induced, but those can potentially cause infarcts as well. And then we have venous causes. So this is one that unfortunately is much easier to overlook, is venous ischemia due to venous thrombosis, whether that's through dural sinus thrombosis or even cortical venous thrombosis. You can cause, if you have that setup, patients can develop ischemia, and venous infarctions are more prone to hemorrhage. So it's important to consider that as well. And then you have the hypoperfusion type setting, in which patients who have really elevated intracranial pressures, high elevated intracranial hypertension, can sort of overwhelm the perfusion pressure, so blood doesn't move forward once it reaches the intracranial circulation. Or kind of the converse to that is when you have systemic hypotension and you don't have enough pressure to adequately deliver the blood forward to the brain. Okay, so as we approach a patient who comes in with a stroke, and keep in mind, stroke is a clinical diagnosis, okay? It's a clinical syndrome of neurologic deficits, and really what we're trying to tease out here is, has the patient had an infarction or do they have ongoing ischemia? So what happens? So immediately there is reduced perfusion to the brain. The brain is being starved of its arterial blood supply typically. And what happens immediately then is we have a reduction in the neural transmission. So it shuts down the action potentials, and it does so by causing dysfunction of the cellular sodium and potassium pumps of the neurons. So early on, from sort of a clinical standpoint or from a physiologic standpoint, you'll see within the first few minutes an elevation of lactate. Then within, say, 15 minutes to a half an hour, we have the onset of cytotoxic edema, something that we're looking for with our diffusion sequences. Over the next few hours, maybe in the range of 3 to 6 hours, you start getting endothelial damage and leaky blood vessels, and that's whenever you get the vasogenic edema setting in. So things that we can image cytotoxic edema and we can image vasogenic edema. They have a different appearance on imaging. The first thing that we will see, the thing that occurs within minutes of that occlusion, of the arterial occlusion, is cytotoxic edema, the thing that we see on diffusion imaging. Give it time to progress. Over the next few hours, you'll start seeing the vasogenic edema showing up on the T2 and flare sequences. And then the later effect, say 12 hours or so on down the road, is we start getting breakdown of the blood-brain barrier. And that's when we may start seeing contrast enhancement of the affected parenchyma. So whenever we're talking about stroke or ischemia, we're talking about what really ends up being a vicious cycle of neurotoxicity. So whenever these neurons depolarize, it causes an influx of calcium. And the elevation of intracellular calcium causes neurotransmitters such as glutamate to be released, and released in massive quantities, or at least relatively massive quantities. And that glutamate then depolarizes other nearby neurons. So they have an increase in calcium influx, and therefore they have increased glutamate release. And so that's sort of an amplification loop. It's a local amplification loop of that calcium influx and glutamate release. So why else do we care about this massive intracellular calcium influx, that's because it activates degradative enzymes. And so those actually cause damage to the cell membrane and other essential neural structures. And then it also results in release of things like free radicals, nitrous oxide, or arachidonic acid that can lead to further neuronal damage. So ultimately, what happens is we have a core infarction of dead brain that increases over time to match what was initially an ischemic penumbra. So ischemic penumbra is brain at risk. Core infarction is dead brain. So early on, we have a region of at-risk brain, the ischemic penumbra. As all of this physiologic stuff is happening in the background with the calcium influx and glutamate release and these degradative enzymes being turned on and dumped out, you end up slowly causing that core infarction to consume what was previously potentially salvageable brain. So as I mentioned, cytotoxic edema, that's going to occur early on, usually within about 15 minutes of the occlusion. And that ischemia is going to cause the ATP-dependent cell membrane ion pumps, those sodium-potassium pumps, to shut down. And so what happens then is as those shut down, you have a rapid accumulation of sodium ions within the cell, within the intracellular space. And water then follows the osmotic gradient and enters into the cells, and it gets trapped there. It gets sequestered in the cells, and the cells swell. And because you have that increased ion concentration gradient, we have water getting trapped in the intracellular space. It can no longer freely diffuse across the membrane. That's what we mean by reduced diffusivity that we're looking for on imaging. So let's sort of diagram this out. So this is our brain cell here. This is our artery here. This is our intracellular space. This is our extracellular space. So immediately what's going to happen is if we have an arterial occlusion, we put a plug into the pipe here. We're no longer delivering arterial blood supply to the brain. Thus, we're no longer delivering oxygen and glucose, which means we're now shutting down the citric acid cycle within the cell. We're no longer able to effectively generate ATP. Therefore, our sodium-potassium pumps get shut down along the cell membrane. We get sodium that gets sequestered into the cell, and water is going to follow along the osmotic gradient. So we've got increased sodium, water follows into the cell, and it gets trapped, and the cell swells. That water trapped within the intracellular space is what we're imaging for with diffusion imaging. Diffusion imaging is a functional imaging modality. So contrast that to vasogenic edema. Vasogenic edema, as I said before, occurs later. We're talking maybe 3 to 6 hours after the initial insult. And what happens is we have an increase in vascular permeability of the arterial structures and in particular the cerebral capillaries within those capillary beds. And that causes extravasation of serum proteins, things like albumin, into the interstitial space and into the parenchyma. And then we have a decrease in the plasma oncotic pressure, which means we have increased extracellular fluid within the brain parenchyma. So cytotoxic edema, again, is when you've got water that's trapped and sequestered within those swollen brain cells. Vasogenic edema is when you get those leaky blood vessels, and we have the protein spilling out and the water sort of getting trapped within the extracellular space in the brain parenchyma. So our goal in terms of treating patients who come in with acute ischemia is to reinstitute perfusion. So reperfusion is our goal. And time is brain. You know, it's I guess cliche, but it's the truth. The earlier that you can intervene, the earlier you can get these arteries open again, the better the prognosis for the patient. So traditionally, when I was learning this, 15 years ago, we learned that if the brain is reperfused within 3 to 6 hours, it causes less cytotoxic edema, and you can still have hemorrhagic transformation, but it's less likely. But then it was sort of like anything after 6 hours, if you reperfuse that, much higher risk of catastrophic complications and hemorrhage. So there were sort of these windows, these 3 and 6 hour windows that were learned. those are moving targets. And in fact, over the last 5 years, probably maybe even 3 years, there's been just a tremendous amount of work that's gone into this, and large, highly powered studies that have come out showing that we can actually push the window further out, maybe even up to 24 hours in certain cases, for endovascular management of strokes. So we'll talk more about that toward the end of this talk, but this is where, as imagers, we're really trying to look at physiologic or functional parameters on imaging that can help predict which patients will benefit from endovascular management, particularly for patients that have a delayed presentation of their ischemia. All right, let's talk about brain imaging. I haven't shown you a single image yet. Now we're going to start showing medical imaging. But first we'll show some gross pathology pictures. So what's your role as an imager? Well, first of all, obviously you want to identify imaging abnormalities. You're trying to figure out the extent of the abnormality, whether there's any urgent complications, hemorrhage, mass effect, midline shift, herniation, all that kind of stuff. As an imager, you really need to utilize whatever clinical information is available. I hate reading stroke cases in a vacuum. Maybe people say, oh, you don't want to bias yourself with the clinical history, but, I want to know. Does the patient have a dense left hemiparesis, or, do they have some numbness and tingling in their right hand? I think that's important because that helps me to know where I need to be looking the hardest in the brain for sources or for the location of ischemia. And then sometimes these patients don't actually have ischemia. There are things that masquerade as infarcts. Sometimes the patient has a brain tumor. Sometimes it's a cerebral infection. Sometimes they're post-ictal, and that can sort of masquerade as coming in with a stroke. And then really, as a radiologist, I tell my residents this frequently. Your job as a radiologist is to be a good communicator, and part of being a good communicator is to close the loop whenever you find actionable things on your imaging. All right, so our first line imaging modality for assessing patients coming in with stroke symptoms is going to be a non-contrast CT of the head. And it has some goals. The primary goal, I think, really is to rule out hemorrhage. Because as I said before at the beginning of the talk, about 15% of strokes are hemorrhagic. So you want to make sure that the patient doesn't have intracranial hemorrhage, because that's going to be a contraindication to thrombolytic therapy. So that's your primary goal. Your secondary goal is then to evaluate for infarction. So, it's been said that maybe somewhere on the order of half of initial non-contrast head CTs are going to be abnormal with acute infarction, even those presenting early on within the first 6 hours or so. But that means that frequently these are going to be pretty normal exams, and that's okay. You're not going to find the ischemia on every single head CT. It's maybe most of the time you won't. So it may be normal. That doesn't mean that the patient is not having an acute ischemic episode. What do we look for acute infarction on non-contrast CT? We look for loss of gray-white differentiation. The density of the cortex should be different than the density of the white matter. When it starts to blur, like this case shows, you have to be worried that we have developing ischemia, in this case, sort of frontal operculum and inferior frontal lobe, and temporal lobe, we're thinking potential MCA territorial ischemia. We also see effacement of the basal ganglia. On this side, we can see the lentiform nucleus. We've lost that on the left. It's very indistinct. You look for the high-density thrombus. There's none to be seen in this particular image, but we look for that hyperdense MCA sign. Keep in mind, not all ischemia is MCA. You got to look for hyperdense ACA, hyperdense PCA, hyperdense basilar. Look at your arteries, and if they're too dense, you have to be concerned in the setting of stroke symptoms that it may be hyperdense thrombus. And then as the ischemia progresses, you get geographic low density or hypoattenuation corresponding with that vascular territory. Obviously, we're on the lookout for hemorrhage. It may or may not be present on that initial head CT. Now, there's something called aspects that I'm sure most of you have heard of. It stands for the Alberta Stroke Program Early CT Score. So why do we care about aspects, and why should radiologists potentially be reporting aspect scores? Well, this is used to grade the size of an infarct. And so we use loss of gray-white differentiation to approximate the infarct volume, keeping in mind that just because you have loss of gray-white differentiation doesn't necessarily mean that that's an area that is dead brain, but it definitely predicts that it's at-risk brain. Now, the aspect score only applies to MCA infarcts. And it's based on a 10-point scale. So 10 is normal, and for each area, each subregion of the MCA, each of 10 subregions that are involved in which you see loss of gray-white differentiation, you subtract a point. So that means that the higher the score, the higher the aspect score, the smaller the area of ischemia. The bigger the aspect score, the lower the aspect score, the bigger the area of ischemia. Now, historically speaking, it's been said that 6 was kind of a cut point in which patients with aspect scores of 6 or greater tend to do better with thrombectomy, and patients that have aspect scores less than 6 do less favorably with recanalization because of increased risk of hemorrhage. And so, they've sort of used some not hard and fast, but use the aspect score to definitely triage who is going to get endovascular management. That being said, this is one of those things that's another moving target, and there have been studies that have come out more recently that show benefit actually of doing endovascular intervention on patients that have low aspect scores. So here's how we divide it up. You slice the brain really at 2 levels. One of the levels is at the level of the basal ganglia, so we call that the ganglionic level. And then the other one, you go up to the top of the lateral ventricles on the axial images, and we call that the supraganglionic level. Okay, so the aspect scores have 3 territories that are supraganglionic, and then they have 7 that are at the ganglionic level. Okay, so that's going to include areas of cortex. So at the ganglionic level, we've got M1, M2, M3, sort of working anterior to posterior. And then at the supraganglionic level, we've got M4, M5, and M6. You just sort of approximate where the loss of gray-white differentiation is at. And then we move it to more of the central stuff. You look at the insula, the lentiform nuclei, the caudate, and then the internal capsule. So you can break it up, again, at 2 different slices into these 10 different subsites, subtract a point for each of the areas where you see loss of gray-white differentiation. So this is what sort of the natural progression of an area of acute infarction is. So this is when the patient first showed up, actually 2 hours after the onset of symptoms on this non-contrast CT. And as I'm looking at this, I don't see much going on at all. There's nothing that catches my eye. In retrospect, I don't know, maybe a little hypoattenuating here. Easy to walk past. I probably would walk right past that. Give it some time. 4 hours later, okay, well now we're seeing this geographic region of hypoattenuation, loss of gray-white differentiation in the insula and in the M1 region. March it out to 12 hours. That area of hypodensity becomes much more conspicuous, kind of getting into that M2 region, sort of sitting lateral to the basal ganglia. And then at 24 hours, much, much more conspicuous. So the density of an area of evolving infarction, the density gets lower and lower and lower over the first several hours, as you can see here. What about a so-called subacute infarction? Man, this is where it gets tough because, there's a clinical definition of subacute which may not match with what you as a radiologist thinks is quote-unquote subacute. One person thinks subacute means one thing, one person thinks it means the other. I think that it gets a little wishy-washy, and not everybody is talking using the same lexicon with that. So if we're talking about what is sort of the definition of a subacute infarction, it's really 2 days to 2 weeks after the initial ischemic insult. So as I mentioned before, the brain density of the involved area of ischemia is going to decrease, so you get lower and lower in density. Mass effect, because you've got increased vasogenic edema, will increase potentially over that time. Now, that mass effect tends to peak fairly early, and then it starts to sort of egress once you get about a week to 10 days in. Now, there's this 2-2-2 rule, and anytime you hear someone talk about a rule in radiology, just take it with a grain of salt. It's nothing is like perfect and hard and fast, but I think this is a useful thing to keep in mind, and this has to do with your enhancement. So this is on CT. We're talking about sort of that patchy and gyral enhancement. And whenever patients have a subacute infarct, if you give contrast on CT, you tend to see that enhancement starting to show up at about 2 days. It's going to peak at about 2 weeks, and it may persist up to 2 months. Okay? Nothing's perfect. Doesn't always follow that rule, but just keep in mind the 2-2-2 rule. So here we can see in this area of subacute infarction involving the posterior temporal lobe on the right. This is a contrast-enhanced CT. You can see that's sort of hyperdense within the dural sinuses. The gyriform density, the cortical density is much greater here than elsewhere, and that's because we're getting that enhancement in a subacute infarct. Now, subacute infarcts can also bleed, so you have to be on the lookout for hemorrhagic transformation, maybe even delayed hemorrhagic transformation of an infarction. What about chronic infarction? Now we're talking something on the order of weeks to months in age. And so it tends to sort of develop this wedge-shaped configuration, as you can see nicely in this diagram. You get associated volume loss. You're going to get gliosis at its margins. And the margins become more and more defined as time moves on. So it's one of those things that as I look at a head CT and I see an area of hypodensity that looks like it potentially is an infarction, the lower the attenuation and the sharper the margins make me think that this is something that's more chronic rather than acute or subacute. You can also sometimes get calcification showing up from dystrophic calcification. Definitely it's in a small minority of cases, but you can see it. So this is an example of what a chronic infarct looks like on non-contrast head CT. We can see there's this sort of wedge-shaped region of really low density. This is almost fluid attenuation. That tells me this is going to be something that's chronic. Very sharply defined margins. And then look at the secondary finding. We've got enlargement of the frontal horn of the lateral ventricle. So that's the ex vacuo dilatation. It balloons up to fill that volume loss. All right, let's talk about CT perfusion. Now we're talking about something that's in the realm of functional imaging. This is a secondary modality for evaluating patients that come in with stroke symptoms. It gets performed after the non-contrast CT, and it can be performed either right before you do the CTA or frequently it gets done right after the CTA. And it doesn't necessarily matter in this day and age. But what you do is, not you personally, but what the software does is it analyzes an arterial input going into the brain and a venous output going out of the brain. And so what we do is we give contrast, we have iodinated contrast, and we monitor that as it transits through the brain vascular bed from arterial through capillary to venous return. And so what that does is it allows for us to evaluate what is penumbra, which again is area of ischemia but potentially salvageable brain, and to differentiate that from infarct core, which is dead brain. Now, it's not a perfect modality. There are limitations to it. One of the limitations certainly is imaging the posterior fossa because of beam hardening artifact from the skull base. That can make it tough. You also have sort of a finite field of view. It's not like we do in most places anyway. It's not as though they do all the way from skull base through vertex with CT perfusion. The other thing to keep in mind is it doesn't really tell you the acuity of the perfusion abnormality. It just tells you that there is one. So a chronic occlusion you can't really tease out what's chronic versus acute very readily with CT perfusion. You have to use the other imaging as well. Okay, so CT perfusion. This is a first pass phenomenon. We are giving contrast and watching it zip through on its first pass through circulation. And what we do is the computer anyway, the software constructs a voxel-based time density function. So you know what pixels are, right? The little dots that make up your TV screen, your computer monitor, or whatever. Voxels are the same thing. It's just essentially, it's just a three-dimensional space. It's a little box, and we can partition the brain up into, numerous tiny little voxels. The density of each voxel is what translates into the color, if you will, how bright or how dark the CT image is. So we do a voxel-based time density function, And what we do is we make the assumption that the brain parenchymal density is proportional to the iodine concentration that goes in. So as we give contrast, the brain parenchyma density increases, and then it's going to, wash out. As the iodine washes out, it's going to return back to its normal attenuation value. So this uses some mathematical modeling, not really important for this talk. There's two basic flavors. Deconvolutional is the more robust, but more technically, mathematically demanding. The other is non-deconvolution, which is more of a simplified approach, and it sort of makes some assumptions, such as the cerebral blood flow is approximated by the slope of your time activity curve, and that'll make more sense here in the next diagram that you see here in a moment. So with CT perfusion, what we do is we lock on to a fixed volume of brain, we target it for the MCA territory, and we give contrast. So we start scanning over and over and over and over and over again. We hit the patient with contrast. We watch as the contrast flows through the arterial phase, the capillary bed, and venous phase. So here's the initial. We're scanning the patient. We can see maybe a little bit of hypodensity in the temporal lobe and occipital lobe. And then we give contrast, watch it wash through, and see how conspicuous that low density gets. So the patient's getting a decent amount of ionizing radiation because we're scanning the same volume brain over and over and over and over again. We have to weigh that risk of ionizing radiation exposure to the risk of missing an occlusion and potential ischemic penumbra. Okay, so we assess this by picking an arterial input function. Here the computer has picked the ACA. The anterior cerebral artery as the arterial input function, and then it automatically picks a venous output function. In this case, it's picking the superior sagittal sinus, or maybe we're down at the torcular at this level, somewhere at that region. And so it's really critically important as you look at these, you look to make sure, hey, did the computer select an appropriate arterial input function and appropriate venous output function? On rare occasions, maybe not that rare, it picks something just totally asinine and crazy. It accidentally picks a vein for the artery. It picks some calvarium for the vein. So you need to, troubleshoot this and take a look and see. And what it gives is it gives what's called a time activity curve. So we have an arterial curve in red here and a venous curve in blue, because, arterial blood is red and venous blood is blue like this. I don't know. It's always named as such, but just keep in mind that's kind of the standard convention of how these work. All right, so this is that time activity curve. So this is where it all sort of boils down to calculus and area under the curve, right? So we have a patient at time 0. We march them out as time progresses. The x-axis is going to be your Hounsfield units, or your density of brain. So low density up to high density. So here's our baseline. We give contrast and we start scanning and watch. And then all of a sudden, it's going to start ramping up in terms of its density of that area of interrogated brain. Okay, so that's your slope. That slope is used to sort of approximate the cerebral blood flow. That's sort of your rate. There's something that's called your time to peak. So we find the peak of that increase in attenuation or increased density, and measuring out from the time that contrast was given out to that's our time to peak. Time to peak is very sensitive for impaired perfusion. Doesn't have specificity in terms of determining if the patient's got ischemic penumbra or core infarction, but it's very sensitive for looking for perturbations in perfusion. And then, you can calculate that area under the curve. And because we know the iodine contrast volume that was given to the patient, we can figure out, what that actual volume of contrast is, that volume of density. So we can then use the mathematic modeling to come up with that cerebral blood volume, the actual amount of blood, the true volume of blood that's contained within that area of evaluated brain parenchyma. Okay, so let's talk about these parameters. Mean transit time. This is a measurement of how long it takes for blood to get from the arterial through capillary and out the venous phases. Okay, kind of makes sense. How long it takes on average per voxel. The cerebral blood volume is a measurement of the amount of blood that's in the brain parenchyma. Again, that's like your area under the curve of the time activity curve. The cerebral blood flow then is a rate. It is the rate of movement across the brain parenchyma, and you can calculate that. If you know the cerebral blood volume and you know the mean transit time, you can create a flow rate. Okay, cerebral blood flow is cerebral blood volume divided by the mean transit time. We talked about time to peak. How long does it take for the contrast bolus to reach its maximal parenchymal density or maximal parenchymal enhancement? As I said before, that's very sensitive for areas of decreased flow. A similar concept is your time to drain. That's how long it takes for the brain parenchymal contrast washout. That's also a very sensitive tool for looking for perturbations in perfusion. Again, not specific, but very sensitive. And then there's something that's called the time to maximum of the tissue residue function obtained by deconvolution. Very long name. It's the Tmax. Tmax is important because many places use Rapid as their perfusion processing software. And so Rapid uses a Tmax greater than 6 seconds to define the threshold of what is ischemic penumbra. It's based on studies that were done when developing that software. So I tend to only highlight things in my slides in yellow if they're really important. There's a lot of important stuff on this slide, okay? You're going to see a lot of yellow. I apologize, but this is one of the most important slides in this whole talk. Okay, so what again is ischemic penumbra? It is potentially salvageable brain. What defines ischemic penumbra? Well, you do see an increase in mean transit time. You do see an increase in Tmax. You see potentially moderately decreased cerebral blood flow. None of that really factors into the definition, okay? The things to keep in mind under the old kind of classic definition of this is that ischemic penumbra is going to have maintained cerebral blood volume, and under like the newer stuff with Rapid software, it's defined as areas of brain parenchymal that have a Tmax greater than 6 seconds. Core infarct, that's dead brain. It, just like penumbra, is going to have elevation in mean transit time and Tmax and time to drain as well. But in the classic definitions, it was defined as having decreased cerebral blood volume. So ischemic penumbra had maintained or sometimes even increased cerebral blood volume. Core infarct was going to have decreased cerebral blood volume. So looking at cerebral blood volume is, historically, that's your critical defining feature for figuring out what is dead brain. That being said, with the Rapid software, we've actually shifted the definition. And if cerebral blood flow is less than 30%, that is what is now used as the sort of surrogate marker for core infarction. So the really critical things to look at, it's all important to look at, but the things that really define things are going to be the cerebral blood volume, Tmax greater than 6 seconds, and cerebral blood flow less than 30%. Okay, so here's an example of what it looks like. I'm not, shilling for this company. Just this is a very common tool that people use, so I'm showing it. This is what it looks like with Rapid CT perfusion, and it sort of gives you these probabilistic maps. On the left, we have areas of cerebral blood flow less than 30%. So these would be the areas of core infarction. You can see those lighting up here. And then on the right, these are areas where Tmax is greater than 6 seconds. And you can see what is ischemic penumbra. So what we're looking for then is a mismatch. We're looking for a mismatch between ischemic penumbra and core infarction. And so it actually will calculate out the mismatch volume and the ratio of the mismatch. And that's important for triaging who may be a good candidate for endovascular management. So you can have quantitative versus qualitative CT perfusion, and there's really some variable accuracy of the different software packages. Rapid probably provides the closest approximation of what currently is out there because it's a quantitative technique, but there are other tools out there that can be used. And so this quantitative rather than qualitative CT perfusion is really better for triaging which patients are appropriate targets for endovascular management. And that's based upon the Diffuse 3 trial that showed that you can push out intervention later, maybe up to 6 to 16 hours range based upon perfusion parameters. And so, sort of that favorable perfusion parameters would be a core infarct volume that's less than 70 milliliters, a larger mismatch ratio, so a mismatch ratio greater than 1.8, and a mismatch volume greater than 15 milliliters. These are not like absolute thresholds, but a lot of places, sort of use this as maybe where the rubber meets the road. So this is a patient that had a favorable target mismatch profile. You can see big ischemic penumbra, relatively small area of core infarction. And so, it spits all this stuff out to you, all this data. You can report it in your reports if you wish. The referring docs may appreciate getting that information. But in this case, everything sort of fit in that category of a patient who would potentially benefit from endovascular management. This is somebody with an unfavorable mismatch profile. You can see the core infarction in this case is much bigger, and relatively speaking, the mismatch ratio was fairly small. As I mentioned, you really, if you're the person looking at the CT perfusions, you can't just totally look at these maps and believe everything you see and trust it. You really have to do some quality control. So as I said before, you always want to check your arterial input function, because if it's incorrectly selected, you can overestimate the mean transit time and underestimate the cerebral blood flow. You also want to check that venous output function, because if that's incorrectly selected, you can overestimate the cerebral blood flow and cerebral blood volume. One of the pitfalls is sometimes it gets selected on calvareal bone because it's pretty dense, and so that can really mess up your CT perfusion and make it useless. And then you want to check those time activity curves. One of the lessons I've learned is to check your perfusion source images. I'll show you a case of that here in a minute. But here is example of just making sure that it looks as though your arterial input function, in this case the A2 ACA, and your venous outflow function, in this case the superior sagittal sinus, those look like they were appropriately selected. Now as we look at our time activity curves, things to keep in mind. The artery, shown here in red, is going to enhance earlier than the vein. It's going to come up, it's going to peak, and then it's going to return to baseline or near baseline faster than venous outflow does. That makes sense, right? Flow in, flow out. The vein is going to then enhance later than the artery. It is going to enhance longer than the artery. Usually, not always, but usually it's going to have a higher peak, and it may have more than one peak, and that's okay. This is an abnormal time activity curve. I don't know exactly what was going on in this case, but obviously, like the vein was peaking before the artery. The artery never came back down to baseline. The vein never probably even reached its peak. So, clearly there was an issue here, whether the patient had a cardiac arrhythmia, they were moving, there was a lost contrast bolus. I don't know. Okay, pitfall case. So this is a case in which a patient came in for symptoms of acute stroke, acute infarct. As we look on the CTA, we can see large vessel occlusion, distal M1 MCA. We can see on the reconstructed image this abrupt cutoff. Actually, this is probably the end of the M2 MCA as well, where we're losing our opacification. And this was the initial non-contrast head CT. Kind of underwhelming. Here was the CTA, and here's the CTP source data. So we did this non-contrast CT, we followed it with a CT angiogram, and then we followed that with a CT perfusion. This is why you need to look at your source data. Let's march that CT perfusion out with time, going through sort of those phases of contrast. So we can see there's an area of hypoattenuation. So clearly there's an area of right frontal ischemia. But the critically important thing to notice is this. We've got a blush of contrast. This is active extravasation. Patient got taken down to the angio suite for thrombectomy. They decompensated on the table. They spun the head real quick, and they saw, okay, this patient had, a massive hemorrhagic transformation of infarction after they were given TPA. So always look at that source data. I think it's really important. You may catch somebody that's actively extravasating on the table. In this case, it was not present on that initial CT. And then within just a few minutes, they were actively pumping blood into their brain parenchyma. So when I view these, I frequently just throw it on Cine mode and do a quick run through of it rather than scrolling through thousands of images. Okay, so here's a put it all together kind of case for you. This patient came in with, right-sided deficits. You can see large region of hypoattenuation throughout the left temporal lobe. If we look at our perfusion, we can see that there's this prolonged mean transit time. We've got very, very low cerebral blood flow, very, very, very low cerebral blood volume. This patient's got a large completed left MCA core infarction. This was old computer software that kind of put together this probabilistic map. You may get something that looks like this, and we can see the core infarct in red, green means go, so small penumbra. I do apologize to the red-green colorblind community. I have no idea why they chose those colors, but they did. Another put-it-together case. The patient came in with right-sided deficits. This is a non-contrast CT. Hey, we've got a hyperdense MCA, this Sylvian fissure segment MCA here is hyperdense. That's hyperdense thrombus. We can see we've got prolongation of the mean transit time downstream of that. We can see that the cerebral blood flow is a little bit reduced compared to the contralateral side, but the cerebral blood volume is actually fairly well maintained, maybe a few areas where it's maybe a little bit down. So this was a large left MCA penumbra with a very small core infarction. And so this was the probabilistic map that was generated, big penumbra. I don't even know if I believe a core infarction that's that small on this. But again, apologies to those who have red-green colorblind. This is just, the cards I was dealt. You can do perfusion on MRI as well. Not as commonly done in the setting of acute stroke imaging, but, some places do triage endovascular management using sort of rapid protocol MR imaging that may include MR perfusion as well. We'll talk about that in a minute. But whether you're doing CT perfusion or potentially MR perfusion, you can sort of apply the same sort of scheme that we did with aspect score to perfusion. Okay, so we'll talk about CT aspects here, and it's going to utilize the cerebral blood volume in this case, because again, historically, cerebral blood volume is what defined core infarction. And so this is going to provide just a more accurate assessment of whether or not the patient has had an MCA infarct or not. Okay, so let's talk about MRI, and then we'll talk a little bit about the MR perfusion that I hinted at a minute ago. But MRI is going to be much more sensitive for evaluating acute infarction than CT. It's going to be our most sensitive imaging technique, and that's because with diffusion imaging, or if you're using diffusion tensor imaging, that's going to be positive. 95% of the time, that's going to be positive within minutes. So within 15 minutes of ischemia, you'll see diffusion signal changes. The flare signal lags a little bit. Maybe half the time it's positive by 4 hours. Virtually 100% of the time you'll see abnormal flare signal in those areas of infarction or ischemia within 6 or 7 hours. And then contrast. Contrast gets a little bit more complicated in the sense that immediately you may see vascular opacification because you've got static blood flow. So the contrast is just sort of sitting in those arteries, and you kind of lose the flow voids. Within 48 hours, you may get some leptomeningeal enhancement showing up over the area of infarction due to, the brain's trying to recruit all these collaterals to reinstitute perfusion. And then, anywhere between 3 days to 3 months, you may see parenchymal enhancement, typically gyroform along the cortex of involved infarction. So the different pattern of enhancement can help to predict the acuity of the infarct as well. This is a patient with an MRI for an acute infarct. In the left MCA territory, we see these areas of very, very bright signal on our diffusion trace. We call this the diffusion trace. Whenever you see that, you look at your ADC map, and we've got matching areas of dark ADC signal. Now, interestingly, there's areas of bright ADC signal as well. So that tells me that this patient has had ischemia of sort of a staggering course. The signal intensity is not uniform throughout the area of ischemia. So it's sort of a staggering course of ischemia. This is either older ischemia or this is vasogenic edema. But at any rate, we've got areas of bright diffusion signal, matched dark ADC signal, and then we've got areas of elevated flare signal as well. This is an example of sort of the enhancement you can see with ischemia. Here on the diffusion, we can see sort of these gyroform areas of cortical reduced diffusivity. Take my word for it, it was reduced. I'm not showing you the ADC here, but it was a bit dark. And here we can see sort of that gyroform enhancement. So this is, probably an infarct that's a few days in age. At least a few days in age. All right, here was that. I was teasing you with a little bit of discussion of MR perfusion. Got a little ahead of myself. You can do MR perfusion for ischemia. Most of the time when we do MR perfusion, we're imaging brain tumors, but it can be done for ischemia. And this was a patient that was a study that was lent to me, or a case that was lent to me by my good friend Aaron Kammer at Indiana University. And here we can see we've got this area in the right parietal lobe of really markedly decreased or markedly abnormal mean transit time. This is actually prolonged mean transit time. The cerebral blood flow was way down. The cerebral blood volume was also way down, corresponding exactly to the area where we see reduced diffusivity with that cytotoxic edema. So this is dead brain. We're seeing restricted diffusion. Almost invariably, that means it's dead brain. You can get reversible diffusion signal changes, very, very uncommon. you can sort of use that as a marker of dead brain with your restricted diffusion. So here we can see the area of abnormal perfusion corresponding with that acute right parietal lobe cortical and subcortical infarction. But there's more. Take a look just sort of globally at the right hemisphere. What is going on here? Well, we've got markedly differential signal. We've got sort of this area of abnormal mean transit time, more subtle, but the cerebral blood flow is maybe a little bit down compared to the contralateral side. But in general, maybe some of these areas here are a little bit down on cerebral blood volume, but mainly it's preserved. Well, that's kind of a head scratcher. It's not just this little area of core infarction going on. Maybe there's something more sinister at play. Maybe there's a more proximal occlusion. So what this is showing is that completed right parietal infarction, and maybe the whole right hemisphere is at risk. I say maybe because when you've got proximal stenosis or occlusion, it really can mess up your perfusion parameters. So they aren't necessarily believable when you have a proximal, extracranial occlusion or whatever. Okay, so again, looking at this case, we've got this whole hemispheric area of prolonged mean transit time. Look at our flow void of our carotid artery. This is our petrous segment, internal carotid artery. Whenever you've got flowing blood, it should be dark on MRI, on T2 and flare and T1. In this case, it's bright on flare. So that's either slow flow or occlusion. Take a look at the post-contrast. We see this actual filling defect, this clot within the carotid artery. So, this patient actually ended up doing pretty well. This ended up just being diffusely abnormal mean transit time because of a proximal occlusion, but the brain was actually able to recruit enough collaterals that it was keeping it alive. So this, very fortunate for the patient, did not translate into a holohemispheric infarction. Just real quickly to talk about these signal changes. The bottom line with this, there's a lot to take in here. The diffusion trace signal is going to increase over the first several days, and then it's going to start to decrease. And the ADC signal is going to be dark, with an acute infarct, and it's going to increase. There is a point at which the patient's diffusion signal changes sort of get back to baseline. Okay, so about 10 to 14 days, the ADC signal, which initially was dark with an acute infarct, it's going to creep its way back up, and it's going to get up to baseline levels. It doesn't stay at baseline levels. At that point, it's going to get brighter and brighter and brighter as those T2 effects from the edema and the gliosis sort of take hold. But we call that time point at which the diffusion signal sort of gets back to the baseline on the ADC map. We call that pseudo-normalization. So, and we'll show you a slide on that here in a moment. So, as I said before, there's sort of wishy-washy terminology about hyperacute, acute, subacute. What it means to me might mean something different to you. Not everybody uses the same lexicon, even though we probably should be on the same page. So, as general rules of thumb, this is how I approach dating the acuity of an infarction. Okay, so general rules of thumb. Nothing's perfect, but these are pretty reliable. With diffusion imaging, we tend to get, on your diffusion trace, you tend to get bright diffusion signal within the first 15 to 30 minutes. Your ADC signal gets dark, all right? You look for that mismatch. Bright diffusion trace, dark ADC map, that is infarction. That is cytotoxic edema, okay? So the ADC signal is going to decrease until about 3 or 4 days out. Then it's going to start to come back up to baseline. And as I said, somewhere in the order of a couple weeks, 10 to 14 days, that ADC signal is going to get back to the baseline brain parenchymal signal. Your diffusion trace signal is going to be bright. Your ADC is going to be ISO. The flare signal, that most of the time with an infarct, the flare signal is getting bright by about 6 hours. T2 by itself, maybe 7 to 8 hours. And then enhancement. You may start seeing that parenchymal enhancement at about 2 days. That can last up to about 3 months. Okay, so this is kind of an important take-home slide. Whenever I'm approaching an MRI for acute infarction, if the diffusion trace is bright and the ADC is dark and the flare is iso intense to the rest of the brain parenchyma around it, that is likely an infarct that's within a few minutes to a few hours in age, the so-called hyperacute infarct. So it's got restricted diffusion or reduced diffusivity is probably better terminology, but normal flare signal. Probably this is very early on in the infarction within a few hours. Now, if the diffusion trace is bright, the ADC map is dark, and flare is bright, then we're probably talking about an acute infarction that's probably between a few hours and a few days in age. Okay, we're talking about an acute infarct. Now, if the diffusion is bright and the ADC map is iso-intense and the flare is bright, then we're talking about, kind of the quote-unquote subacute infarction, but more specifically, this is a subacute infarction that's likely on the order of several days to a couple weeks in age. Probably, around that 10 to 14 day time frame. So here's a pseudo-normalized infarct. And actually, this is interesting because there's sort of ischemia of varying ages here. But on our diffusion trace, we've got lots of areas of bright signal. Okay. Whenever I see bright signal on the diffusion trace, I look at the ADC map. ADC map here, at least in this area, is iso-intense. And it's bright on flare. So bright on the diffusion trace, iso-intense on ADC map, bright on the flare. This is a pseudonormalized infarct that's probably on the order of a couple weeks in age. Here we've got some areas that have bright diffusion signal, and they're also bright on the ADC map, and they're also bright on flare, so those are probably older than a couple weeks in age. What about chronic infarctions on MRI? So in the chronic phase, that damaged brain tissue becomes phagocytized. Okay, you've got PMNs, you've got macrophages that come in, they clear out all of the dead brain, and you end up getting volume loss. And with that volume loss, you frequently get ex vacuo dilatation of the adjacent lateral ventricle, and you get this sort of phenomenon of encephalomalacia and gliosis forming. You can also get what's called laminar necrosis, cortical laminar necrosis. This is really a petechial hemorrhagic transformation, okay? We always worry about hemorrhagic transformation of infarcts, and this is where, I report it in my reports, but I always kind of, hate doing it because, yes, there is a form of hemorrhagic transformation, but this is sort of a benign, normal, expected hemorrhagic transformation. You sort of just get this ooziness of the cortex. It's this very fine petechial hemorrhagic transformation. This is not like an infarct that has developed a parenchymal hematoma or exploded out into the subarachnoid space with hemorrhage. This is, just sort of the normal evolution of infarction. All right, so this is a look at a chronic infarct. There's actually, again, good case that shows sort of, variable appearances of things. But let's hone in on just this one spot right now, this little hole in the brain. Doesn't really have any diffusion signal abnormality associated with it. It's actually dark on the diffusion imaging right in the center. That little center area is bright on the ADC map. It kind of follows CSF. And there's this little hole in the brain that's been formed with all this sort of gliosis around it. So this is a little area of cystic encephalomalacia from an area of lacunar infarction. Here we can also see this confluent ADC signal hyperintensity. This is due to the T2 effects. We can see it's very bright on the flare. It's kind of unremarkable in the diffusion. So this is sort of encephalomalacia and gliosis also in the frontal lobe. Another good look at how a chronic infarction can appear. Here we've got our flare image. We've got this area of sort of volume loss, but it has this sort of curvilinear, bright flare signal within it. That's interesting, right? Look at the cortex there. This is our T1 sequence that's very bright compared to the rest of the cortex. The cortex should be kind of darkish on T1. This is bright. Look at our susceptibility image. This is a sequence that's very, very sensitive at looking at blood products, and we can see there's gradient susceptibility. So there are blood products that have locally warped the magnetic field there. So this is an example of what cortical laminar necrosis or petechial hemorrhagic transformation of the cortex looks like. All right, so we've talked about the brain imaging. Let's move on to vascular imaging. So, in this day and age, CT angiography is done, it feels like on every person who wanders into the ER. Like you just have to get a CTA before you can even be seen. I know that's not the case, but it feels like it. So CTA is rapidly available and it is rapidly ordered. And so what is our goal with CTA for looking for infarcts? It really is to look for sites of occlusion that are contributing to the ischemic event. Potentially it's also look for sites of potential sources for embolic disease as well. This gets done really kind of in the same setting as that non-contrast CT. Long gone are the days of taking the patient to radiology, getting the head CT, interpreting it, and making the decision, maybe we should get a CT. No, it just all gets done at once now. So what we're doing is we're doing a detailed look at the intracranial and extracranial arteries, and we're looking for large vessel occlusions, which are potential thrombectomy targets. We're looking at the extent of atherosclerotic disease and looking at the morphology of areas of atherosclerosis and trying to figure out, are those kind of risky areas of athero that could be contributing to infarctions. We also want to look for other things like dissections, sort of those less common causes of infarcts. And then obviously we're looking for incidental aneurysms as well. So this is a patient with a CTA of the head. We've got 3 slices at 3 different levels. Here we've got a segmental occlusion of the left M2 MCA, maybe a little contrast sneaking through it, but predominantly we've got a large vessel occlusion here. Look downstream of that. Some of the branches within the sylvian segment here are not as dense as others. Compared to the contralateral side, you can see there's asymmetry between the normal right side and the abnormal left side. That's probably seen a better effect on this image as well. So what we've got here is we've got a left M2 MCA occlusion with impaired downstream flow. This would be a potential target for endovascular management in an appropriately triaged patient. What about imaging of atherosclerosis? Well, traditionally, the focus of imaging atherosclerotic disease was just to quantify the degree of stenosis. And that's based on lots of studies, probably the most famous, the NASCET trial. Your risk of stroke does increase as carotid stenosis increases to a point. And so medical decision-making in terms of which patients need, say, either a stent placed or carotid endarterectomy depends on the degree of stenosis. So there are different imaging modalities that we can use to assess stenosis. We can use ultrasound, CTA, or MR angiography. Very rarely is conventional cerebral angiography done for this in this day and age. Here's where all of this breaks down with stenosis, okay? As it turns out, your risk of having a stroke in a patient who has a near occluded carotid artery actually decreases. So yes, the worse the stenosis, the higher the risk of having a stroke up to a certain point. In which case, the stenosis gets so severe that, it effectively acts like an inline filter. And the other thing to keep in mind is that just looking at the data, most strokes actually occur when there's less than 50% stenosis. So stenosis is important, but it's not the only thing. And I think we have to get out of that mindset because, that's pretty much all people think about when they think about CTAs for athero is how bad is the stenosis? Yes, it's important, but it's not the only thing. So let's look at the modalities. Carotid ultrasound, quick and cheap, readily available. This is really an indirect assessment of stenosis. We're looking at peak systolic velocities, and I think it's the Bernoulli principle. Don't quote me on that, physicists. You might get angry at me. But if you look at the peak systolic velocity, as the caliber of the vessel gets narrowed by stenosis, the velocity increases. And so it's sort of an indirect measurement of that. The problem is, it's always operator dependent. It's patient body habitus dependent, sure. But if they've got really dense calcification in their carotids, that can also impair ultrasound assessment. And this is really the lowest accuracy tool we have. CT angiography, this is really kind of, I think, the first line modality now. It's quick, it's widely available. It's great for looking for plaque ulceration. It requires iodinated contrast material, so if patients have allergies to it or if they have impaired renal function, that's a consideration. It does expose them to ionizing radiation as well, but you weigh that against the risk of having a future stroke, and that's obviously much more significant than that very minuscule lifetime risk of developing cancer from getting the CTA. But it's limited in its assessment of the vessel wall. It's not totally useless, but it's limited. We'll talk more about that here in a minute. And then MR angiography. This is nice because it requires no ionizing radiation. And it really gives us our best assessment of intraplaque hemorrhage and intramural hematoma. It does not require contrast, although I will say contrast-enhanced MR angiography of the neck is superior in my mind. And you do it without than with, so you get the best of both worlds. You can do 2-dimensional or 3-dimensional time of flight. Time of flight is that non-contrast MRA. So you can do either 2D or 3D. If you have the option of 3D, it really should be done because it's superior to 2D. And here we can see, kind of the normal appearance on the left side. On the right side, we have sort of this loss of the flow-related enhancement, this narrowed carotid bifurcation and proximal ICA. And then MRI, if we're doing that kind of imaging, that allows for us to potentially perform vessel wall imaging. Intracranial vessel wall imaging has been around for a little bit, and that's picked up a lot of steam. I think that extracranial vessel wall imaging is really kind of up and coming, and it's getting to be used more at larger sites, and I think it's extraordinarily valuable in predicting sort of how risky different types of plaque are. So this is an area that I think that in the next decade we're going to be seeing done much more routinely. Okay, so how do we grade carotid artery stenosis? It's graded based on the NASIC criteria, and it gives us a percent of stenosis. So how do you calculate this? Well, you calculate this by doing two measurements. You do the narrowest diameter, and you pick whatever plane, sagittal, coronal, axial, whatever, you get the narrowest luminal diameter at the point of maximal stenosis, and you measure then downstream at an area of normal vessel. Now, I don't love this image in the sense that it's showing it this close to the stenosis. In reality, you should be measuring much more downstream of that because of a phenomenon called post-stenotic dilatation. So frequently, the vessel just distal to an area of stenosis will balloon up a little bit, and that will actually, if you use that measurement, that will make the stenosis more severe than it really is. So I go a ways down, multiple centimeters down the vessel to a normal caliber. So it's really the distal normal measurement minus the stenotic measurement divided by the normal measurement and multiply that by 100. That gives you your percent stenosis by NASIC criteria. This is something that Scott McNally taught me when I was a fellow. He'd be disappointed to know that I'm terrible at remembering numbers, but if you're good at remembering numbers, this can actually be a super nice life hack because you really only have to measure once rather than two spots. If you can remember three measurements here, really two measurements actually, 1.4 and 2.2. So if you have the stenosis greater than 2.2 millimeters, there's no flow limiting stenosis by NASIC criteria. If it's between 1.4 and 2.2 millimeters, we're talking about that 50 to 70% range. And then if it's less than 1.4 millimeters or 1.3 millimeters or less, then we're talking about greater than 70% stenosis. And we care about with NASIC criteria, really what matters is it less than 50% stenosis? Is it between 50 to 70, or is it greater than 70? And really, if it's greater than 70, they will likely treat it, even if the patient is asymptomatic. If it is between 50 and 70 and they're asymptomatic, they're not probably going to do anything. But if they are symptomatic, then they may do either a stent or do carotid endarterectomy. So it really matters, A, is the patient symptomatic or not, and B, how severe is that stenosis? And so if you can remember 1.4 and 2.2, that may save you some time. I just suck at remembering numbers, so I will probably for the rest of my life be somebody that gets stuck measuring because I always have to look these up. But this is published, this has been vetted, and it's a good life hack if you can remember the numbers. Just an example of how you measure these. Here was an area of maximal stenosis. I'm not measuring it right here for the comparator. I'm going way downstream so I can get an accurate assessment, okay? So this ends up being greater than 75% stenosis per NASIC criteria. Okay, so what's best? What's the best modality? Well, studies have looked at this, and really there's no significant difference between CTA or MRA versus the gold standard of DSA, digital subtraction angiography, for stenosis, okay? If you look at the accuracy, MRA is 95% accurate, CTA is 97% accurate compared to conventional angiography. That's really good, okay? That's acceptable. MRA and CTA both outperform ultrasound, which is about 75-76% accurate compared to the gold standard of conventional angiography. So, there is a role for ultrasound, absolutely, and we talked about the benefits to it before. But if you're looking for an accurate assessment, CTA or MRA is going to be better. As I said before, there is more to atherosclerotic disease, though, than just stenosis. And so one of the things that we really need to shift our focus toward is looking for intraplaque hemorrhage, okay? That's because patients who have intraplaque hemorrhage, they've got hemorrhage within the atheromatous plaque, they have a significant increased risk of having a stroke, okay? That plaque can rapidly progress to occlusion, or it's a setup for, because of the local inflammatory response, developing a little more extra clot there that can embolize off. So intraplaque hemorrhage is very concerning. We also can look for plaque ulceration. Now, plaque ulceration in of itself is not necessarily a surrogate marker for intraplaque hemorrhage. Just because you have a plaque ulceration doesn't necessarily mean you have intraplaque hemorrhage, but it is a significant predictor for it. So if you have plaque ulceration, you're at increased risk of having intraplaque hemorrhage, thus increased risk of future stroke. So how do we look for intraplaque hemorrhage? We use a special sequence, like an MP-RAGE sequence with fat saturation is a good sequence. You can use T1 weighted imaging with fat saturation as well, but really the MP-RAGE technique is better. And for looking at it, you can also use time of flight MRI as well and get a sense for intraplaque hemorrhage. But here's an example of a patient who had some plaque. We're slicing it through this level. So here's our eccentric plaque right here. This is the image of the level of acquisition of these axial sequences. Here we look at this MP-RAGE sequence, which is a T1 weighted sequence, and we can see just how bright that is. This isn't flow-related enhancement within the artery. This is hyper-intense because of blood products within that plaque hemorrhage. And here we can see a little bit of heterogeneous signal as well. We can sort of see that luminal narrowing, but MP-RAGE is going to be most sensitive for looking for intraplaque hemorrhage. So when you see this is a risky patient. This patient is a patient who has an increased risk of future stroke. So what is the risk of intraplaque hemorrhage and ipsilateral stroke risk? Look at this odds ratio of 25, okay? And this may actually be one of the leading contributing factors for patients who have a stroke, but less than 50% stenosis based upon NASCET criteria. So yes, stenosis is important, but it's not the only thing. We need to be changing our mindset and looking for plaque hemorrhage as well. So as I've mentioned a couple times now, carotid stenosis alone, not the best marker for stroke source. But patients who are symptomatic, whether they're having, amaurosis fugax or some, TIAs kind of stuff, if they have symptoms and they have intraplaque hemorrhage, they have a very, very highly increased risk of future stroke. We're talking like between 15 and 45% annual stroke risk. Okay, so intraplaque hemorrhage is a big deal, and it's something that we need to be doing a better job looking for. Plaque ulceration, as I mentioned, not a true surrogate marker for intraplaque hemorrhage, but it is a significant predictor. In the study from the Utah Neurovascular group, they found an increased odds ratio of 4.25 for plaque ulceration, predicting intraplaque hemorrhage. Okay, so that was all talking about MRI. The question is, MRI, maybe it's not readily available. Maybe the patient can't go into the scanner. Maybe it's not practical to do it in everybody up front. Is there anything that we can glean as a biomarker on CTA to predict intraplaque hemorrhage? Well, as I mentioned, CTA is very sensitive for looking for stenosis. We can look at plaque thickness. We can see little ulcerations within the plaque as well, and we can see intraluminal thrombus. So CTA is great for that stuff. But as it turns out, it's also useful in its assessment of atherosclerotic calcification. And we can sort of break atherosclerotic calcification in the extracranial ICA and carotid bifurcation into three basic buckets. Okay, so the three types. The first type is the positive rim sign, and that's defined. I'll show you images of this here in the next slide. But positive rim sign are patients that have carotid bifurcation, proximal ICA, atherosclerotic disease in which the adventitial calcification is less than 2 millimeters in thickness, but they have overlying internal soft plaque, that eccentric atheromatous plaque that's 2 millimeters or greater in thickness. So again, positive rim sign, sort of thin calcification, thick eccentric plaque. Negative rim sign is when you've got thin calcification, but minimal or no overlying internal soft tissue plaque, so it's less than 2 millimeters in thickness. And then you've got bulky calcification that's greater than 2 millimeters in thickness. Okay, so those are the three things we can see on CTA. Here's our example of a positive rim sign. thin adventitial calcification, really thick, in this case, very thick, eccentric atheromatous plaque. This is the residual lumen. This is a patient with a negative rim sign. They still have thin atherosclerotic calcification, just very trace overlying plaque. And this is our camp with bulky calcification, just really dense calcification. Okay? This is where we need to be recognizing things on CTA as a potential biomarker of plaque ulceration and of intraplaque hemorrhage. And then this comes from a study from Scott McNally at the University of Utah, and I think this is kind of a game changer for me in terms of how I approach these patients. Okay, so there was a study by Laura Eisenmenger who looked at this rim sign in terms of predicting whether or not patients have intraplaque hemorrhage. And as it turns out, carotid intraplaque hemorrhage is highly associated with that rim sign. Prevalence ratio of 5.3, very decent area under the curve. So this patient with a positive rim sign, kind of less than 2 millimeters thickness of calcification, greater than 2 millimeters thickness of eccentric atheromatous plaque, these patients have an increased risk of intraplaque hemorrhage. So therefore, this may be a CT biomarker of unstable plaque, regardless of the degree of stenosis and regardless of whether or not we see ulceration within it. Kind of a game-changing concept here. All right, we're going to talk very briefly about endovascular management. So I'm not a neurointerventionist, so this is going to be a very general overview. But this is stuff that I think is just good, baseline knowledge that if you're dealing with stroke patients or stroke imaging that you should know. Okay, so what is our very basic general algorithm for working up patients with stroke symptoms? Well, it all starts with a non-contrast CT of the head. If we see a large territory infarct, very, marked hypodensity within that territory, or if there's hemorrhage, we're kind of done. It just moves on to standard traditional care. To do all the medical management, blood pressure control, all that stuff, but they're not going to be an endovascular candidate. What if the non-contrast CT of the head is normal, or it shows just a small territory of loss of gray-white differentiation? Our next decision point is to look at the CTA. If the CTA does not have a large vessel occlusion, either an M1 or M2 MCA, A1 or A2 ACA, P1 or P2 PCA, basilar artery, extracranial carotid artery kind of stuff, if there's no large vessel occlusion, then they fall back to sort of that standard management camp. But if there is a large vessel occlusion, one of those major arteries that you can get to with a catheter is occluded, then they may just take them straight to endovascular management based upon, symptom, time of onset and stuff. But this is an area where you can also look at the CT perfusion and sort of help to triage things a little bit better. So if on CT perfusion, the patient does not have ischemic penumbra, it goes back to standard care. If there's no salvageable brain, there's no point in doing a declot. But if CT perfusion shows significant penumbra, then patients may be triaged to endovascular management to try to suck that clot out or apply thrombolytics, although mechanical thrombectomy and suction thrombectomy really is kind of more standardly used now in terms of getting the clot out. Okay, so stroke intervention, what kind of things can be done? Well, you can give thrombolytics. These are like serine proteases that convert plasminogen to plasmin, things like TPA. Kind of the traditional approach was within the first 3 hours of onset of symptoms, you can be administered intravenously. If they're within the first 6 hours, can be administered intraarterially with catheter-directed thrombolysis, and historically very strict criteria for administration. Well, things have changed quite a bit over the last several years because of multiple studies that have come out, and we'll talk more about that in a minute. The other potential things are mechanical thrombectomy, and so this is much more commonly used now than intraarterial catheter-directed thrombolysis. The thing that probably gets used the most is like a suction thrombectomy, where you just get the catheter up and you start sucking the clot out. But there are other things you can use, like stent retriever devices. Put a stent up, and the clot goes into the interstices of the stent, and then you take it down and pull the clot out. So, this is an area where new devices come online every so often, and those trends may change. But the most important thing to keep in mind is, based on very high-powered quality studies that have been published over the last 5 years or so, the therapeutic window has gone from 6 hours out to 24 hours and maybe getting pushed even further. So here's just kind of an example. I think this is a stent retriever device. If I remember, the catheter goes up, you put this the stent-like thing in there, and all the clot kind of gets into the interstices of the stent, and then it sort of gets retracted back out through a shuttle that pulls this clot out with it. So in terms of doing this, whether you're doing suction thrombectomy, mechanical thrombectomy, intraarterial thrombolytic thrombolysis, really what you're trying to do is you're trying to recanalize that clot, because recanalization is correlated with improved clinical outcomes. There's a grading for this, unless you're a neurointerventionist, or if you're a neurologist, stroke neurologist that's taking care of these patients. It is important to know what these mean, but in general, it's all based upon, and we call it TICI, thrombolysis and cerebral infarction scale, the TICI scale. It's all based upon sort of the spectrum of TICI 0 is complete occlusion and TICI 3B is normal perfusion of the entire territory. And so our goal of endovascular intervention is try to get the patient up to, at least a TICI 2B, if not higher. So here's an example: conventional cerebral angiography, patients that has an M2 occlusion. So kind of a TICI 0. We don't see any downstream opacification in that segment. They were successfully recanalized. That vessel is opened back up. A little erratic, but that's okay. We're not looking for perfect images. We're looking for just improved perfusion. This was, at least a TICI 2B. So this is a successful recanalization. So, in terms of the drugs that are given, intravenous TPA, if there was no intracranial hemorrhage on CT and the symptoms were less than 3 hours, those patients get IV TPA, and I think that's probably still kind of the standard on that, and that's based on this National Institute of Neurologic Disorders and Stroke trial. And the first drug for this came online in 1996. So this isn't anything new. We've been doing this for a long time. These are, potentially if you're at sort of like an outside facility, not a level 1 stroke center, patient comes to you, they've got stroke symptoms, they don't have any evidence of hemorrhage on head CT, or they don't have a big area of hypodensity, they will likely get intravenous TPA, the clot busting drug, and then, if possible, transferred to a higher level stroke care center. There was a study, the ECAS-3 trial, that looked at this and found that if there's no intracranial hemorrhage on CT, IV TPA can actually be pushed out to 3 to 4.5 hours. Now, this was, at least as at the time that I put this talk together, still considered off-label use in the US. Just know that those hard and fast guidelines are evolving over time. So it may be you can push IV TPA later than 3 hours. Now, lots of studies prior to 2018 showed that thrombectomy could be extraordinarily useful in appropriately triaged patients up to 6 hours. Lots of different trials. I love something like Mr. Clean, whoever names these trials, they're awesome in my book. But so lots of trials showed supportive data for doing thrombectomy up to 6 hours. Well, things have changed. Really, in 2018, the Diffuse-3 trial was published, and that looked at patients with proximal MCA or ICA occlusions that had core infarct sizes less than 70 milliliters and decent penumbra to infarct ratios greater than 1.8. That's why these numbers that we talked about earlier in the talk with CT perfusion matter. They showed that you can do thrombectomy up to 16 hours. And these patients had better functional outcomes than just getting medical management alone. And when they looked at the adverse events, they were really similar, no significant difference. Then there was the Dawn trial that looked at proximal MCA or ICA occlusions, and they allowed patients in that had a mismatch between the severity of their deficit and their infarct size, and they found that thrombectomy can be considered up to 24 hours with better functional outcomes than medical management and no difference in adverse events. So these are moving targets, and the data is going to keep getting better, and we're going to potentially find out how far out we can push thrombectomy. So we're much more aggressive about it now than we used to be. So I'll wrap up very briefly by talking about some future directions. And, as I mentioned before, it's sort of moving goalposts for these endovascular interventions. And we're using more and more advanced imaging modalities to selectively and appropriately triage these patients. I think that in terms of workflow, everybody talks about AI and machine learning. Well, the reality is it probably is going to make a difference in stroke management, because you'll probably see more and more of these tools being run on the, sort of in the background and looking at these studies and triaging your workflow because it identifies somebody that maybe has intracranial hemorrhage, or maybe it identifies a large vessel occlusion, or maybe it identifies somebody that, based upon pulling data from the chart, from the medical record, can figure out the time of onset of symptoms and sort of look at the CT imaging appearance and say, hey, this may be a patient that should be shunted toward more aggressive management. And then vessel wall imaging, which I'm not going to get into in this talk. This could be, hours worth of content in and of itself. But I think that as that becomes more and more a mainstay, we're going to be looking at not just imaging the lumen of vessels. So, to this point, most of what we do for vascular imaging is luminograms. Now we're going to be looking at the actual walls of the vessels and looking at the enhancement of the walls of the vessels to look at inflammatory markers that can show us, really, do patients have increased risk of having vulnerable plaque? Or, not really, stroke per se, in terms of ischemic stroke, but predicting the risk of rupture of intracranial aneurysms. So I think that we're just going to see more and more of that high-end kind of stuff. And these were some images lent to me by Scott McNally, looking at, black blood vessel wall imaging, looking at this kind of circumferential enhancement of the MCA here in this patient that had inflammatory atherosclerotic disease, looking at permeability changes of the vessel wall. We saw this intraplaque hemorrhage. Maybe diffusion has a role for looking at that as well. So with that, I know there was a lot of information, but this was sort of a general overview of imaging of acute stroke from a diagnostic radiologist perspective. We talked a little bit about the pathophysiology, a lot about the imaging workup, and a little bit at the end here about the endovascular management of things. And hopefully covered a decent tour of the current state of things and where I think the future direction of stroke imaging is moving. But, if anything, keep in mind, the old adage, yes, it sounds cliche, but yes, it's also incredibly true. Time is brain. So these are studies that you need to approach rapidly, accurately, and make the findings to help the patient out, but not just make the findings, but also close the loop, okay? As a good radiologist, you have to be a good communicator. And there's a patient on the other end of things whose life and livelihood really depends on you providing accurate and timely care. And so I think this is an area where really, as a radiologist, you need to be a good communicator and be in close contact with the stroke team and let them know about these findings if you see something. So with that, I thank you for your attention. I've got lots of other video content on this channel, educational video content. So feel free to check it out and enjoy. Thank you.